So I'm going to hand over now to Allan, Stephen on the program, Steve on Zoom, who's going to present the third paper. Over to you, Steve.
Thanks, Martin. Hopefully you can see my slides just loading up.
Yep, we can see it. Thank you.
Thanks, Martin. So I'll apologise in advance because I can't now see my screen, but sometimes on Zoom, I suddenly lose all connection for various seconds. So if I do go, someone will just have to shout and tell me to start again from where I've been lost. And I do apologise if it does happen. So I'm going to present to you some research on the economic determinants of English home care quality. This is research in the NIHR policy research in adult social care in ASCRU, and it's work by myself and my colleague Florian Bedayan from the PSI University of Kent. Okay, so as a rationale for this work, it's important for policy to understand factors that affect the quality of care in social care and also to what extent. And that's important because we're looking to sustain and improve the quality of social care services and the workforce. And ultimately, as has been discussed by Jose Luis in the previous presentation, to ensure that public funds are ultimately spent efficiently. And of course, staff play a key role in the delivery of home care and of all social care services. But there's a lack of quantitative research evidence in particular for England and the UK around the effects on quality of social care and the determinants of that. So the objective for this work was to determine the factors which affect English home care provider quality, and we're able to include some staffing factors in that analysis. In terms of previous research, there is some work from the US around home care quality, and once you control for the characteristics of the users, or at the provider level, the average level, average service user characteristics, then you find that home care provider quality differs by sector. So for-profits compared to not-for-profit providers tend to have higher costs through a greater use of service or higher cost per patient, and they either have lower quality or no difference in quality. So they're either providing a higher cost at a lower quality, or there is less efficiency in the delivery of the same level of quality. Home care quality also differs by location, certainly by particularly urban rural differences in home care provision, and that can be seen from the particularly around the distances travelled, for example. For the UK, there's more limited evidence specifically for home care, kind of a process outcome. We can say there's differences by location again, because some research that was funded by the
Okay, we've lost Steve. Come back, Steve, you're all forgiven.
Factors that affect care home quality, and we have found that a number of staffing factors influence quality, significantly influence quality, such as retention levels, job vacancies rates, and wage as well, with increases in wage significantly increasing care home quality ratings. So the kind of background that we're using to underpin this analysis is the production of welfare approach, and so it's just putting together the resources and non-resource inputs that go into the output of home care, with the final output being the well-being of those that use the services. And so, as Jose Luis was saying, ideally we'd love to be able to have that quality of life measure to be able to include in the analysis, but we don't have that specifically when we're looking at a national level analysis like this. We have to use something as a proxy, and as what we use for this analysis is the CQC quality rating. But we have shown in some other research led by my colleague Anne-Marie Towers that there is a positive relationship at care home level between a resident's social care quality of life, social care related quality of life, and care home quality ratings. So there's some indication that the CQC quality ratings, which are based on the MUM test, do link with the quality of life of residents in care homes at least. In terms of data for this analysis, we were using the adult social care workforce data sets, which is the leading source of intelligence on the adult social care workforce. And we used data for home care providers in 2016 to 2018. I realised just a few minutes ago that I haven't actually given you any information about the numbers of home care providers in this slide. So I can say that we've got over 7,500 observations in this analysis across those 3 years. And that includes data for over 3,750 home care providers, and at least 1,100 of those are seen across all 3 waves. So we've got good representation. The adult social care workforce data set is a voluntary submission of data by social care providers, and it covers about 50% of the national.
Okay, Steve, we're not hearing you again.
Level information on their quality rating. So we put together the lower quality ratings of inadequate and requires improvement, and the higher quality ratings of good and outstanding to create a binary quality rating variable. And that's simply because inadequate ratings and outstanding ratings are generally fewer and far between. So a very low percentage of providers will be rated as inadequate or outstanding. Then we've also got provider level information on the provider sector in terms of private or voluntary, their size by staff, and their registration status in terms of who they are providing support for, be it those living with dementia, older people, or those with learning disabilities, and so on. The staffing data, we look at provider level, we look at the care worker average wage, the staff to service user ratio, indicators of training, vacancy and turnover rates, the prevalence of 0 hours contracts for employees, and the prevalence of female staff. What the adult social care workforce data set does not have is further information on the clients that are supported by the home care providers, other than for example, their registration status. So we match this to local area data as well, to proxy for the needs and demand factors as well as supply factors. And so we have indicators for commission decisions, the average LA unit cost, supply, the level of competition, and female job seekers allowance uptake. We also have a measure for needs in terms of benefits, proxy for benefits being attendance allowance uptake. And for wealth and income, we have measures of average house price and pension credit uptake at the local area level. In terms of our statistical methods for this analysis, because we're looking at quality ratings, well, then we can use a latent probability model for this analysis. So a home care provider is assumed to have an actual level of quality, which is dependent on staffing factors and other provider level characteristics and user characteristics. But then when they're actually observed for their quality by an inspection, and also using the other methods that the CQC uses, then that will be based on a decision rule that that level of quality will be decided, and we can assume that that level of quality will be dependent on whether their actual quality crosses some threshold level, which we can assume to be, for simplicity here, we assume to be 0. So for this analysis, we estimate a linear probability model, which is just basically simply OLS model for estimating observed quality rating, which is the recommended method of analysis used even with binary data for the dependent variable for the other statistical methods that we use. And in particular, that is when we're instrumenting for wage using panel data. And we do that because we expect there to be some endogeneity in this relationship between quality and wage. in particular. So, for example, that circularity could happen. We're trying to look at the wage effect, how that does that influence quality, but it could quite easily be that a provider could reward staff with a higher wage from an increase in quality. We also use multiple imputation to address missing data. I won't go into too much detail on that. Okay, mean sample characteristics. So these are the characteristics at the home care provider level, the general provider level characteristics, and also their care worker characteristic, home care worker characteristics at the provider level. And we've present these by mean and proportions by quality rating. So we've got inadequate and requires improvement on the first column and good and outstanding on the second column. And then we've got a simple univariate test of the difference in mean or proportion between by quality rating of these means or proportions of these characteristics. And so we can see that there are, when not controlling for other factors, there are certainly some significant differences between lower quality and higher quality home care providers. So we generally see that relationship again between the voluntary sector. We also see that there is less competition faced by those providers that have higher quality, and they tend to be more likely to be smaller. And then for staffing, we also see that they have definitely have a significantly fewer employees employed on 0 hours contracts with no fixed hours of work, and they have significantly higher direct care worker to service user ratio, and they also have a significantly higher average hourly wage. But certain other factors aren't significant as well, such as turnover rate. Not significant differences when just comparing simple means between turnover rate and vacancy rate, for example. For the average hourly wage, that difference is significant, but lots of other factors could be playing into that. For example, the voluntary sector and private sector, we tend to find that voluntary sector providers will pay a higher wage. And we can see that in this next diagram. So we've got the two, looking at the home care worker average wage by sector and quality rating here. So the first two parts here we're looking at lower quality inadequate requires improvement, and the second half of the diagram we're looking at the higher quality, and this is by private sector and then voluntary sector within quality, and then within those quality ratings. And so what we can see is that if we look within the quality ratings, inadequate and requires improvement, we see that this voluntary sector does pay a significantly higher wage. So this is the average wages are in the squares, and the level of confidence we have in those estimates are in the represented by the lines. And so we can see that within quality ratings, the voluntary sector pays a significantly higher average hourly wage to their care workers, home care providers do. But when we look within the sector, we will see significantly different wages between quality ratings as well, even controlling for the sector. It's certainly the case for the private sector, not necessarily the case given our levels of confidence for the voluntary sector, and that is generally simply because there are so few voluntary sector providers, home care providers, that are rated as inadequate or requires improvement. I think it's less than 1% of the observations we have. Okay, so that's when we look at it in terms of a simply comparing without controlling for other factors. When we get to the regression analysis, our results are as such. And so I'm just presenting here the findings for the staffing factors. This is when we control for all the provider level factors and all the local level characteristics that we've matched in to the data. We've got 5 columns of results here. I'll just simply explain that CC represents complete case, and so is when we don't allow for any control for any missing data, so we just use the data we observe. We expect these results to be biased. And then MI is multiple imputation, so is when we address for the missing information. RE is random effects, so it's simply the panel level data. And so we're controlling for that panel level. Across time, we're able to control for the changes in time that occur, and also therefore can cluster our standard errors by the home care provider. Linear probability model, as I already outlined, just means we're doing running OLS models, except for in the fifth column where we run a similar model but with probits. And then IV is instrument variable, where we control for the potential endogeneity of wage in the analysis. And so the final three columns we do that. And then the fourth column, we look at the model when we just look at those registered to provide care to older people, as well as potentially registered to provide care to other people as well, but also definitely older people. What do we find? We find that the mean hourly wage does not have a significant effect on the likelihood of a higher quality rating, of being rated as good or outstanding. We do see that as we move through the models, the estimates increases through these first four columns, suggesting that there is an underestimate in models that don't control for the endogeneity, which is what we found in our analysis for care homes as well. The direct care worker to service user ratio significantly increases the likelihood of a higher quality rating, but generally at a decreasing rate, which is what you would expect. So there is a quadratic relationship going on, some evidence of a quadratic relation going on at least. And then we also find that the presence of 0 hours contracts has a large effect on the significance of the likelihood of a higher quality rating, with greater prevalence of 0 hours contracts reducing the likelihood of a higher quality rating. So 1 percentage point increase in 0 hours contract proportion at the mean would decrease the likelihood of a higher quality rating of good or outstanding by over 7%. So that's quite a strong effect going on. So the results for staffing, they're outlined there from that table. The other factors we found in the analysis that I don't present in a table for speed and brevity today, we find that there's higher quality for providers in the voluntary sector, so like the US analysis, and also there's some indication that wealthier areas have higher quality as well, but that needs further research, which is ongoing. There is lower quality for providers that are registered to support older people that face higher competition, and for some of the underlying key lines of inquiry indicators, such as caring and responsive, we find that larger providers, medium and large providers, have lower quality. So smaller providers have more likely to be have a good or outstanding rating. And we also found that the LA average hourly unit cost did not significantly influence home care provider quality in our multivariate model. Okay, in terms of a discussion around those staffing factors, so we found that quality is linked to those staffing factors. More staff to service users increases quality. So that makes sense in terms of, for example, more frequent or longer visits would be enabled with that. The potential for double up care for those with the required needs that need two carers to support them safely. And we do find that the effect of the staff to service user effect on the likelihood of higher quality is strongest for the safe key line of inquiry. We also find the higher proportion of staff on 0 hours contracts reduces quality. That could be in line with some qualitative research which has found that those who are employed on 0 hours contracts have added stress points to their role as a domiciliary care worker compared to those who are on fixed term contracts, on fixed hours contracts, sorry. And then we find that wage is not a factor in determining home care quality, provider quality. This finding is different to the previous care home analysis. We have a few potential reasons for why that might be, that I won't dwell on just now, but maybe we can get into in the discussion, the questions. In terms of policy implications, we can certainly say that there's a few things we can certainly say from this analysis, although there are limitations to this analysis. I haven't gone on to the kind of limit. I haven't included those in these slides, but certainly there are limitations to this analysis. But what we can say is that one policy kind of main aim at the moment is improving recruitment and retention in the social care workforce. And we've shown that for social care conditions of employment, such as contract type for home care workers and also wage for care home workers, it would seem, is an important factor driving quality in social care. And so that's something that needs to be bared in mind as as policy looks to ways to improve recruitment and retention. We then also need to consider competition effects of the growing market, because home care, as Jose Luis showed in his previous presentation, the home care market is growing rapidly and has grown rapidly over the last 10 years. And as a number of providers grows and as competition grows, that is having a negative, seems to be having a negative effect on quality of the providers, or the likelihood of higher quality. And so that needs to be also needs to be considered. And in general, the quality of a service is likely to be important. This is probably the key caveat of this analysis. We can't say to what extent it is important. We can only say which types of providers are less likely to have a higher quality rating. We can't say what will be the implications of that. We need to know what the implications of that are. But all local authorities need to have a range of high quality services. And it is potentially the case that the difference in quality could have an influence on the overall public health and social care spend, which is important moving forward, but we need more research to analyse that. And I will just quickly finish with this disclaimer, just like everyone else, and say thank you very much. Any questions?
Thank you very much, Steve. So do you want to stop sharing? So perfect timing, everybody. Thank you. Okay, so open to questions or comments. Jonathan.
So just a point on the wage issue. I'm a bit worried that wages in home care are hard. The true wage is hard to observe because workers are typically paid by the contact hour, and that requires some sort of factoring in of travel time to the wage. And yeah, you don't really know how much you're really being paid until you know how much travelling you're expected to do. And so I wondered if you thought that might be a concern at all.
Yes, that's precisely it, Jonathan. Yeah, so thanks very much. Yeah, that is the precise reason we expect to be why we haven't necessarily found a significant wage effect on quality for home care providers, is that we are unable to discern on whether providers are paying for travel time or not. There are other potential reasons that we can potentially look at. For example, we could say that maybe home care providers have very little variation in wage, but we don't see that in the data, so we think that's unlikely. But yes, overall, we would definitely point to that difficulty in the data, and so we'd need better data on wage to be able to discern that.
Thank you. Okay, so Alice, next, please.
Yeah, and just following on from that, a couple of things. Could you hypothesize that if quality is affected by the staff ratio, then you could look at, it could be impacted by, if there's a better staff ratio, you're less likely to do kind of unpaid overtime, and then that affect quality. And then the other thing I wanted to ask about was the female staff proportions. Why was that? What was the hypothesis behind that could affect quality?
Yes, certainly in terms of, so taking each point individually, and yeah, great points. In terms of the service user to direct care worker to service user ratio, yes, certainly there's a number of reasons why that effect could be being found in terms of when you're looking at quality ratings. So it could simply be a process thing, and that's again limitations, potential caveats to this analysis is when we're looking at CQC quality ratings, what are they looking for? Are they looking at, potentially they will be looking at, are there a safe number of staff for delivery of appropriate care? But your point on overtime is quite right as well, in terms of they could be capturing that. In terms of female staff, I think that was mainly included in the analysis as an additional proxy towards staff attitudes, potentially. I don't necessarily expect is more of a control variable rather than for specific hypotheses in the analysis. There's more to kind of control for potential non-resource inputs into the output of home care.
Okay, thank you, Simon.
Thanks, Steve. That was really, really interesting. The thing that most struck me about it, if I understood it, and you whizzed through it quite quickly, was that there was no linkage, no correlation between the average unit cost paid by a local authority and measures of quality. And I found that really interesting and surprising. But did you have thoughts about why you might have found that?
Yeah, thanks, Simon. Yeah, that is a point I kind of did whiz across without kind of reflecting on, but yeah, I was hoping it would be brought up. So thank you. Yeah, in terms of the analysis, so we did find a univariate difference when we looked at it simply before controlling for everything else. So we did find it that LA unit cost was significantly lower for those with that were rated as inadequate or requires improvement when we looked at it as a univariate, just simply without controlling for all the other factors. When we include all the other factors, we didn't find that relationship. So whether it's there are two potential factors driving that, is we're not able to discern the difference between home care providers in terms within local authorities, whether they're being paid different rates. So they might be paid different rates on the framework agreement. They might not be paid. They will be paid the same rate generally, but there might be more cause for some local authorities might use spot contracts more often with higher rates because of which generates better outcomes potentially. So that could be one way. We need to have more granular information at the provider level. And then secondly, it might be being captured by other factors. So I mentioned that wealth was seemed to have some small indication. It's a very weak significance in some of the models that higher wealth drove higher quality. And so that's through pension credit, the pension credit variable. So it could be that that's where the kind of it's being found of the effect on of LA unit cost is the wealth effect is found there. Those who are more likely to be using the service are those with less income and therefore more likely to be supported by the local authority. So there's a couple of potential reasons, or it is the case that there isn't an effect. But we'd need further information and further research to look into it in more detail. But yeah, great question.
Okay, thank you. And just Joe Moriarty put into the chat, if you're not able to access the chat, it says gender and home care is complicated factor as men more likely to work in learning disability / mental health settings. So yes, I mean, do you want to come back to that, Steve?
Yes, so thanks, Joe. That's a great point to reflect on.
Okay, I'm going to